Welcome everyone. My name is David Houteman. I'm a product manager CT at Medis, and I would like to welcome everybody to this symposium on plaque analysis with CT. We're very excited because we have three excellent speakers lined up, all experts in their field. And the three speakers, they will introduce each other. So without further ado, I would like to give the word to the first speaker, Marton Kolossváry.
Yes, thank you so much. It's a great pleasure to be here, and I would like to introduce Parastou Eslami, who has a background in biomedical engineering from Stanford University, and she obtained her PhD at Johns Hopkins University working on computational fluid dynamics modeling and patient-specific vascular flow based on CT imaging. Currently, she's a postdoctoral fellow at MGH and is an instructor of radiology at Harvard University.
All right, I will introduce Dr. Budoff. Dr. Budoff is a preventative cardiologist, and he's passionate about earlier identification of patients at high risk for cardiac events and progression of atherosclerosis. Much of his work is around cholesterol and CT scanning. He has a bachelor's from University of California, Riverside, and has obtained his MD from George Washington University. Currently, he is a professor of medicine at David Geffen School of UCLA and working as an investigator at the Lundquist Institute as a program director and director of cardiac CT and division of cardiology at UCLA Medical Center.
Okay, and it's my pleasure to introduce our first speaker, back to Marton Kolossváry. He's received his medical diploma from Semmelweis University in 2016. He has a PhD in characterization of coronary atherosclerosis using advanced imaging processing techniques. He was a postdoctoral fellow at Johns Hopkins and currently a postdoctoral fellow at Harvard Artificial Intelligence in Medicine program. He has a great interest in precision phenotyping of diseases using radiologic images and will be our first speaker for today's symposium.
Thank you so much for the kind introduction. So I would like to speak about the latest advancements in coronary tissue characterization. These are my disclosures. As you all know, in our clinical practices, when we describe coronary artery disease, our first objective is to rule out coronary artery disease. So basically, we're making a binary classification if the patient has or does not have coronary artery disease, or we might also say if it's obstructive or non-obstructive based on anatomical imaging. But of course, this way we're losing out on a lot of information. So we sometimes also characterize the extent of the disease. We have created numerous quantitative metrics for this, such as how many segments are involved, meaning the segment involvement score. We have created the Lehman score, and these all help to characterize the risk of the patients, but we're still losing out on a lot of information because these have only described the extent of the disease. However, if we want to describe the quality of the disease, basically, if there are components of the plaque structure which might have characteristics predictive of later outcomes, we might use high-risk plaque features. There are studies which have also shown that these have additional value in identifying high-risk patients. But then again, these are all visual descriptors of coronary artery disease and therefore do not have the best reliability between the readers to identify these patients. And also, we are still losing out on a lot of information because radiological images are actually physical measurements where we have a exact measurement in each voxa representing the density of that tissue structure, which might have information. So we need some kind of method to analyze this. For this, we can use quantitative analysis. Medis provides this software, QAngio CT, which is able to basically quantify coronary artery disease volumetrically, which means that using this software, we are able to identify the coronary vessels and outline the areas which have plaque. And based on the radiodensity of these areas or volumes, we can characterize plaque tissue components. And as you can see here, based on this, we can identify high lipid-rich areas, fibrofatty areas, or calcium. And we can also visualize this in 3 dimensions. Using this information, several studies have shown that this volumetric analysis is additive and provides superior classification of patients to, which potentially have adverse outcomes later, even at a 10-year span. So basically, using this, we're able to increase our diagnostic accuracy to identify patients above and beyond clinical characteristics, clinical evaluation of CAD, and hemodynamic characteristics of the lesion. And therefore, this is a very additive approach. However, we're still looking at only plaque volumes, and is it enough? Professor Budoff will talk more about current studies that are implementing these plaque volume measures. But I would like to also move on to a different territory, which basically asks the questions, is plaque volume enough to describe coronary artery disease? For example, here you can see two very different coronary artery lesions. But if we just quantify plaque volumes or describe, for example, the mean attenuation of these lesions, we get same values, while visually we can see they're very different plaques. So how can we quantify this? We can do this using radiomic analysis, which is basically another domain of quantitative image analysis. Instead of only looking at volumes, we try to quantify heterogeneity and the spatial pattern of these lesions and subcomponents. So basically, we're extracting new information from the radiological images, increasing our available feature set. And then we can use, for example, machine learning on these or other precision phenotyping methods to identify new CAD characteristics or phenotypes which are predictive of later outcomes. So using this analysis, it has been shown, for example, that high-risk plaque features such as the napkin ring sign can be identified. As you can see here in a study which compared in a matched case control study, the presence of the napkin ring sign, basically these plaques were matched based on all characteristics except for this marker, and the radiomic features significantly outperformed conventional features in identifying these plaques, as seen on the ROC curves to the right. And this can also be used, for example, for precision phenotyping, where it has been shown that different clinical risk factors, for example, HIV or cocaine use, have a very different effect on coronary artery disease manifestation and progression. And they not only affect plaque volumes, but also plaque structure. As for example, the structural components affected by conventional risk factors were different from those that were affected by HIV and cocaine use. And these results seem to be very significant without any overlap, indicating that actually risk factors may have unique contributions. But it's not only the plaques that we're interested in. Recent research has shown that pericoronary adipose tissue has also very valuable information regarding patient characteristics. And using the new version of Medis, we're able to quantify this pericoronary fat tissue. And this, for example, has been shown to be predictive above and beyond high-risk plaque features in the patients. And basically, in this way, we're adding a new information domain to our clinical evaluation, not only looking at plaques when we're describing coronary artery disease, but also looking at the pericoronary fat tissue. So in conclusion, we can basically say that volumetric analysis increases our ability to characterize CAD. And using the tools of Medis, we're able to extract these features, being that volumetric, or using that volumetric information for radiomic analysis. And it seems that these analyses are able to further characterize patients and their disease to identify, for example, high-risk morphologies, or, for example, to identify new pathways of plaque progression. And it's not only the actual plaques that we're interested in, but also the pericoronary tissue, which seems to be of interest. And using these information, hopefully in the future, we will be able to provide more specific personalized care for our patients. With that, I would like to thank you for your kind attention and give over the talk to Parastou.
Thank you, Martin. Hello, everyone, and thank you again for the invitation. I will be covering advances in computational fluid dynamics and coronary plaque and the state-of-the-art advances there. Okay, why do we need hemodynamics? We just listened to Dr. Kolossváry looking at plaque structure and showing us that plaque anatomy is not enough. In fact, we know that from large trials such as PROMISE, Goodhart's, Iconic, Prospect, plaque anatomy and morphology are not enough to identify the vulnerable plaque. Therefore, the majority of the coronary plaques, including high plaques by anatomic criteria alone, remain quiescent, and other physiological factors must be crucial to cause plaque destabilization and an acute coronary syndrome. And we do need a hemodynamic factor to kind of guide us through that. How do we do this in details? Computational fluid dynamics comes into play, and we would use CFD to do a detailed analysis of hemodynamics. So what is hemodynamic or computational fluid dynamics? It's basically a combination of fluid dynamics and numerical methods that would allow us to study problems involving fluid dynamics. The study of aerospace industry has started from 1930s, looking at CFD simulations around the boats, fluid structure around the rocket. However, really biological flows and anatomical flows have been lagged for 50 plus years. And the reason for that is the complexity of human anatomy and incredible complexity of human hemodynamics. And we have kind of caught up in the past 15 years, and we need to first and foremost talk about FFRCT, which has really revolutionized the connection between the engineering community and the clinical community, adding this non-invasive FFRCT through computational fluid dynamics. I will just briefly talk about the details of how a CFD calculation works for patient-specific modeling. You start with an imaging modality of interest. We're focusing on CTA here. Then you create the anatomic model of coronary arteries, segmenting the arteries, and then impose physiological boundary conditions for circulations, which are ideally patient-specific. Here in stress and rest conditions, and then you input it to your flow solver to solve these Navier-Stokes equations, which are highly nonlinear, and then look at the post-processing information that will be extracted from the fluid velocity and pressure information that the flow solver gives us. And this last step, which I'm showing here, is the FFRCT, can be adjusted to whatever need that you want. For example, you have FFRCT, you have endothelial shear stress, or plaque structural stress, or axial plaque stress. So it is this last step that actually carries and changes through different CFD applications. Now, we know that FFRCT is kind of like the most well-known CFD application through many trials, such as Platform, Hot Flow Next, Discover Flow, and you name it. And it is really the ground work that the CFD is shown to be very powerful in this region. Now, there are other hemodynamic factors that can be solved, as I mentioned, through CFD. And one of them is endothelial shear stress, or ESS, which is a tangential frictional force against the wall imposed by the hemodynamics. And here on the top, I'm showing you an undisturbed flow looking at normal FFR and physiological shear stress. However, when you have a plaque with a necrotic core at the minimal lumen area, you can see a high shear stress, high shear stress and also high FFR value causing a ischemic flow. And also on upstream of it, you can see low endothelial shear stress and oscillatory promoting plaque progression. And at the downstream of it, you can see this low ESS imposing inflammation shown by the presence of macrophages. Now, ESS has been shown in intravascular ultrasound that is associated with the progression of coronary artery disease. We also have seen from other studies that high ESS has been shown to be associated with MACE. So there is a discrepancy there of like what is responsible for what, but ESS has been proven to be a very important hemodynamic factor on top of FFRCT, give us more in-depth of the relationship with the morphology of the plaque rather than just the physiology itself. And this really comes into play when we want to target a higher number of patients. As I showed you, most of the evidence for ESS is based on an invasive imaging modality. And the question is, can we target higher number of patient populations to identify vulnerable patients before they go to invasive therapy, before we put them in the cath lab? And we actually designed a study to study exactly that, to focus on CTA, to see if we can use the two imaging cohorts that we had at MGH and Erasmus MC to compare the invasive and non-invasive imaging modality in capturing the shear stress. And for this, after the co-registration between the two imaging modality, we segmented and created the models based on IBIS or OCT, and we repeated the same methodology, looking at the construction of coronary CTA and segmenting it with the Medis software here. And the results are showing a representative case with a high correlation between the two imaging modalities. On the top panel, you can see the comparison between the 3D shear stress and the 2D cross-sectional shear stress pattern, the categorical shear stress pattern, which has been shown to be an important predictor in literature based on IDIS studies, and oscillatory shear index, which is another hemodynamic factor proven to be important in plaque analysis. Now, here's the cumulative results looking at the segmented averages with a very high correlation between our training patients and testing patients. And looking at the blunt unknown patients, as you can see, there's a systematic overestimation of shear stress based on based on non-invasive imaging, but the categorical values and also the correlations remain really high. So that's very promising that actually CTA is capable of capturing the same pattern of time average wall shear stress. And this can be really the groundwork for any other further CTA studies that would give us the shear stress pattern to look at plaque morphology in the future and its correlation. So this is the last slide, which kind of talks about the future of CFD and how we can use the coronary plaque information and mapping on it. This is one of the best and newest advances of the coronary plaque visualization through the 3D workbench at Medis, that you can see that you can clearly have the plaque information, and we can really use this towards our advantage and map the shear stress, for example, or FFR onto this 3D display of coronary plaque, and easily find the correlation between them, as I mentioned, which is very important because that's the next step to compare with the invasive modalities. Another application of this 3D workbench is to use and study plaque structural stress, which has been shown that in high values of plaque structural stress, that's when the plaque ruptures. And we can use this FSI simulations or fluid structure simulations of coronary, looking at the hemodynamics and its interaction with the plaque and the coronary wall to study this map of other hemodynamic factors with plaque morphology. With that, I'll thank you, my mentors and my mentees, and I'll take I'll transfer it to Dr. Budoff.
Well, thank you very much, Dr. Eslami. That was a great presentation, and certainly wanted to just build upon that by talking a little bit about some of the latest advances in clinical studies that are now available. So we have the capability now of using programs like QAngio CT to track atherosclerosis over time. We can take an image on the left at baseline. We can randomize patients to different therapies and then follow them up a year later, or 6 months later, or 18 months later, and see what changed and get plaque quantification. Now, a basis for this is really the need for very high reproducibility. And this is data that we published using QAngio CT that we published in JAMA in 2017, just showing a very high reproducibility using this software. And that was really the basis for us to be able to publish some of the trials that we've demonstrated changes over time. Here you can see the effect of testosterone. This is from that same study that we published in JAMA, but this is now a excuse me, a randomized trial of testosterone versus placebo, a double-blind placebo-controlled trial, demonstrating that testosterone in red actually causes plaque progression as compared to placebo. And you can see the different components of the plaque: low attenuation plaque, the vulnerable plaque that Martin talked about, fibrofatty plaque, fibrous plaque, all changed proportionally adversely with testosterone. There was really no significant difference with dense calcifications. More recently, at the European Society of Cardiology, we presented this presentation, the EVAPORATE trial. This is another prospective double-blind placebo-controlled randomized trial looking at serial CT angiography using QAngio CT, randomizing patients to icosapent ethyl, or EPA, or placebo, and following them over 18 months. Now we can see placebo in red, and we can see progression of atherosclerosis. It should be noted that everybody was on background statin therapy, but there was a very high prevalence of metabolic syndrome. All patients had high triglycerides, and 70% had diabetes. So it's not surprising that on statin monotherapy in red, you can see some progression of atherosclerosis. But what we were able to show, and subsequently published in the European Heart Journal this year, is regression of atherosclerosis, a slowing of plaque and a trend towards regression of almost all of the components of atherosclerosis, including low attenuation plaque, fibrofatty plaque, and fibrous plaque. You can see calcification really didn't change much as expected, but total non-calcified plaque and total plaque all moved in the correct direction and were highly statistically significant. So we can demonstrate the effects of different therapies. And of course, the icosapent ethyl has also been shown to reduce cardiovascular events in the EVAPORATE trial. If we look at a host of different trials that have been done, these are CT angio trials and cardiovascular outcome trials using the same interventions, you can see a great correlation between the ability to see changes on CT angiography using serial plaque progression and the subsequent outcome trials that have been done. Statins cause regression and have great positive outcome trials. Estrogen was neutral with CT angio. We showed that 2 years ago in the New England Journal of Medicine. And the cardiovascular outcome trials are also neutral. You can see the fish oil data, the icosapent ethyl data we just presented. Testosterone caused progression, and in the TOM trial has shown to be harmful. And of course, colchicine at the bottom, very important, showed regression of atherosclerosis on CT angiography and has now very positive outcome trials in both the LIDOCO-2 and COLCAT studies. So great correlation between CT angio and progression of atherosclerosis. We can also look at the natural history of atherosclerosis by looking at serial changes. This was a study that was recently published on the natural history of diabetic coronary atherosclerosis. This is the Paradigm study, part of the CONFIRM registry, looking at serial CT with a host of authors from around the world contributing cases. And you can see overall, no statin, there was more plaque than in the statin group, highly statistically significant in patients with diabetes, still with progression though in both arms. And you can see calcified plaque actually went the opposite direction, but non-calcified plaque very nicely slowed, not regressed, but slowed under the influence of statin therapy. This is a study by Dr. Hausleiter's group looking at 10-year risk stratification and showing us that plaque volumes, here a total plaque volume in red being high, predicted cardiovascular events, moderate plaque volumes in yellow, and no minimal or zero plaque volume in green, showing the best outcomes. So plaque volumes can predict outcomes and can help us with net reclassification. You can see the up arrows demonstrating where the total plaque volume was greater than 110. increasing the net reclassification, and in green, those patients who had zero plaque, decreasing or reclassifying patients correctly. It can also be added to the Maurice score. Here on the left is the score by itself. On the right is adding total plaque volume, and you can see better plaque risk assessment. Finally, I just want to mention an ongoing trial, another study of serial CT that we're performing, looking at semaglutide, a GLP-1 receptor agonist. The hypothesis is that the GLP-1s will reduce progression of non-calcified plaque volume, looking at serial CT over 1 year, and that might be the primary effect that these new therapies have demonstrated. So in conclusion, changes in atherosclerosis on CT are highly correlated with outcome studies. QAngio can be used to quantify plaque volumes to improve risk stratification, improve net reclassification, and track atherosclerosis over time. Thank you very much.
So thank you very much, Dr. Kolossváry, Dr. Eslami, and Dr. Budoff for your very nice presentations. I hope everybody enjoyed it as much as I did. Before closing this symposium, I would like to mention that new features that already were mentioned by the speakers are now available in the latest Medis CT software, December 2020. So this includes the PVAT analysis for the perivascular adipose tissue, and also the workbench to visualize 3D plaque and the lumen. And apart from that, there's several other nice features added, such as a CT strain analysis. So if you're interested in our latest version or have any questions or would like to learn more about the new features, please reach out to us. We're happy to talk with you about these developments. So yeah, with that, I would like to thank everybody for joining this virtual symposium and the speakers for the great talks. And hopefully in 2021, we'll be able to meet again in person at Medis. We really look forward to that very much. So for now, thank you, goodbye, and see you next time.